So some of the myths. This is a popular list that I helped compile with one of my colleagues in primary care, actually. Just spoiler alert, none of these are actually true. But this is sort of widely believed in the general population, including among healthcare providers, and I think it represents a bit of a barrier to care. But they don't actually make people vomit. They do work. We can easily control anemia and malnourishment and prevent those. The vast majority of procedures are laparoscopic. The death rate is lower than that of a total knee or a lap chole. You don't have to use liquids henceforth. You can use appetite suppression if you've had surgery. And surgery is definitely not a last resort. I think that last myth is the one I'm most passionate about teaching, is that you really, it's part of our armamentarium of treatment of obesity. It is not a last resort, and you don't have to have a patient who looks like they're at death's door to recommend them for surgery. So some facts, dispelling the myths here, the facts in contrast. The majority of surgical patients are women, by a lot. It's more than you'd think. And so quite a few of them are reproductive age women. This is one of the most effective treatments for infertility, actually, in PCOS. Most US adults are obese. Carol alluded to that. The average BMI of a surgical patient in this country is 49. So that's a big person. And it's rising. Most of them do have some measure of chronic disease that isn't just obesity, but obesity-associated chronic disease. The sleeve is now the most common operation. That is a recent change in the last 5 years. It used to be the gastric bypass, and mortality is quite low. Most cases are laparoscopic. We were over 200,000 last year, and I bet we crossed 300 in the next 2 annually. And there are universal recommendations from our surgical society for case-appropriate vitamins based on what surgery you have to prevent malnourishment, anemia, vitamin deficiencies, et cetera. This chart I actually think is a little bit difficult to read, and I apologize about that. But the relevant x-axis here is BMI. You see that along the bottom. That applies to all the graphs. Being obese obesity kills people. And the all-cause mortality related to obesity is directly proportional to the BMI. And so you can see, regardless of how long you're following the patient, the bigger they are, the higher their mortality. And the same is actually true once their BMI is below a certain threshold, if they're underweight as well. But this really illustrates the scope of the problem. And you can see it, 10 to 15 years out, if your BMI is 45 or higher, you have a 3-fold relative risk of all-cause mortality. And that's not specific to a disease process. That's just the burden the excess weight is on your body. This is a paper looking at, the obesity epidemic, and the conclusion that they drew, just to highlight the final sentence: it's clear from this review that the morbidity and increased mortality of overweight and obesity are substantial and should prompt further attention toward the need for appropriate weight management in healthcare. So please do not dismiss it. It has to be addressed. It really is a harmful disease. There we go. So specific surgical options. How do we define success? I think that's a really important thing to understand. You're not necessarily going to get these patients to a normal BMI, but that is okay. There are a lot of weight-independent benefits to these surgeries. They're not just weight loss operations. They really are more relevant as metabolic operations. You're making your patients metabolically healthier. And so if they lose more than 50% of their excess weight and they maintain it for 2 to 5 years out, that's considered success. And for your patient with a BMI of 49, the average patient, that does not mean that their BMI is now 24.9. It's not. It's probably in the high 20s or low 30s, but it's a monumental improvement in their long-term outlook. And then procedural options. The numbers that are next to these here are the percent of the total surgical body of work in the US. And you can see the sleeve is by far the most dominant. And I'll talk about each of these as we go. And then this is the sort of scale of bariatric surgeries being performed within the US over we used to be able to say the last 6 years, but slightly outdated. They need a new one. But you can see it's rising. It's becoming more and more popular. And that's good because we are becoming more and more obese as a nation. So how do we choose? What operations are out there, and how do we go about choosing them? So the first one I'm going to talk about very briefly is the lap band. And I only bring it up because I'm sure if you're dealing with